Hemodynamics of Constrictive Pericarditis. Restrictive physiology. Restrictive physiology is characterized by impediment to ventricular filling caused by increased ventricular stiffness (RCM), increased pericardial restraint (CCP). Constrictive pericarditis and restrictive cardiomyopathy share clinical features and hemodynamic findings. Preserved systolic function. Grade 3 diastolic dysfunction. Elevation and equalization of diastolic pressures. Dip and plateau pattern in ventricular pressure tracing, pericardium. Pericardium 2 layers. Visceral monolayer of mesothelial cells, collagen and elastin fibers. Parietal layer collagen and elastin fibers. Visceral layer reflects back over origins of great vessels. LA largely extrapericardial. Pericardium physiology. Pericardium can restrain cardiac volume. Contact pressure exerted on the heart can limit filling when upper limit of normal cardiac volume exceeded. Contribute to diastolic interaction BW cardiac chambers. Constrictive pericarditis. Scarring of both visceral and parietal layers constraining cardiac chambers. Causes: tuberculosis, idiopathic or viral pericarditis, mediastinal irradiation, open heart surgery, CRF, connective tissue disorders. CCP pathophysiology marked restriction of filling. Ventricular interdependence. Failure of transmission of intrathoracic pressures to intracardiac chambers. Restriction to cardiac filling. Physiologic effect produced by constricting pericardium. Gradual development of systemic and pulmonary venous hypertension. Atrial pressures 10 to 18 mm of mercury. Systemic venous congestion. 18 to 30 mm of mercury. Upper dyspnea, orthopnea. Fallen stroke volume. Increased HR, systemic vascular resistance. Inability to augment cardiac output during exercise fatigue. Resting COP. False cachexia, ventricular interdependence. Filling of one ventricle limits the simultaneous filling of other ventricle owing to the shared mechanical constraint. Coupled constraint tamponade. Greater ventricular interdependence. Uncoupled constraint. Modest interdependence. Predominant effect on the thin-walled RV. Loss of transmission of intrathoracic pressures. Normal. Inspiratory decrease in ITP transmitted to all cardiac chambers. Decrease in pressure in pulmonary veins and LV. Decrease in PCWP accompanied by corresponding decrement in LV pressures. Gradient that drives LV filling maintained. Normal. CCP pulmonary veins, LA extrapericardial. Inspiratory decrease in ITP transmitted to the pulmonary vein and LA but not to LV. Decrease in PCWP not accompanied by corresponding decrease in LV pressures. Less gradient that drives LV filling. Inspiratory decrease in LV filling. Allows increased RV filling and IVS shift to left. Opposite occurs in expiration. Horrell DG et al. Circulation 1996-93, 2007-2013. Copyright American Heart Association, CCP. RA pressures. Restricted filling. Elevation of mean pressure. Early diastole. Rapid filling. Prom. Y descent. Elevated rap. Suction effect due to decreased TSV. Friedreich sign. Abrupt cessation of ventricular filling. Nadir of Y descent. Kussmaul S sign. Inspiratory increase in venous return. Dicker. ITP. Failure of transmission of Dicker. ITP to RV. Ventricular interdependence is modest. Ventricular pressure tracing. Equalization of LV and RV pressures. Ventricular interdependence. Early diastole. Filling of ventricles unimpeded. Rapid high rap, decreased ESV. Ventricular RFW greater than 7 mm of mercury. Abrupt halt to ventricular filling once the limit set by the pericardium. Dip and plateau pattern. Equalization of LV and RV pressures. Ventricular interdependence. Rivet 1/3 RVSP. Discordance BW RVSP and LVSP during phases of respiration. Feature sensitivity %, specificity %. Rivet less than 5 mm Hg 6038. Rivet/RVSP greater than 1/3 9338. PASP less than 55 mm Hg 9324. LVRFW greater than 7 mm Hg 9357. Respiratory rap less than 3 mm Hg 9348. Respiratory pop, LVPG greater than 5 mm Hg 9381. LV, RV interdependence 195. DG Horal circulation 1996. Horal DG et al. Circulation 1996 /93, 2007 to 2013. Copyright American Heart Association. Systolic area index. RV area/LV area in inspiration divided by RV area/LV area in expiration. Greater than 1.1 SOCCP. Feature sensitivity %, specificity %. Rivet less than 5 mm Hg 4654. Rivet/RVSP greater than 1/3 9346. PASP less than 55 mm Hg 9029. LVRFW greater than 7 mm Hg 4544. Respiratory rap less than 5 mm Hg 7137. Systolic area index greater than 1.197 100. Dr. Talrage Jack 2008 51 to 315. Echo M mode septum poster wall sharp F slope in MVM mode. Rapid movements in early diastole and atrial contraction. Poster wall. Abrupt poster motion in early diastole and flattened diastole. Sharp F slope in MVM mode. Echo Doppler mitral peak E velocity 25% increase in exp. Tricuspid peak E velocity greater than 25% increase in inspector. DT less than 160 ms, IVRT less than 60 ms. EA ratio greater than 2. Echo features Doppler. PV Doppler SD prominent atrial reversal. Increased velocities in expiration, mitral and PV flow in CCPT. Hepatic vein Doppler S less than D in inspiration, S greater than D in expiration. Diastolic flow reversal in expiration. HV diastolic flow reversal in expiration. TDI. Mitral annular E 8 cm per second. E/E less than 15.